Good afternoon. Thank you for joining us for our webinar on an introduction to Central Coast Health at Home. My name is Phoebe James and I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Some housekeeping to begin. This session is being recorded and will be available on the PHN website under the Education Library in the next few days. At the end of the presentation, there will be a Q&A session, so please put your questions in the question box and we will answer as many as we get to. Today, presenting for us, we have the wonderful Dr. Ellie Warren, Medical Director, GP Staff Specialist at Central Coast Health and Home. I'll now hand over to Ellie.
Thanks, Phoebe. It's great to be with you guys in a busy lunchtime. Thank you for giving us a precious 30 minutes. Hopefully this is an enjoyable talk. Some of you may have known about this already or heard some of this before, but it's a great opportunity to let you know about this wonderful new service setting up at Central Coast LHD, and it's free. So myself and Catherine Palmquist, another GP that's well known in the area, are the new medical co-directors of Central Coast Health at Home. But before I get into the talk, I would like to acknowledge the traditional owners of the land on which we're meeting on today, and pay my respects to elders past and present. And I really do need to acknowledge the lasting impact that the referendum result will have on our First Nations community, who've been told now that they don't have a right to recognition or self-determination, and we really need to support our Aboriginal colleagues, friends and fellow coasties through this tough time and help them regain strength after this blow. It's certainly our responsibility to create culturally safe spaces in our workplaces to encourage access and improve health outcomes for Darkinjung community. This is our Central Coast Health at Home team down at Pearl Beach, spending a day with Uncle Gabby Duncan, very well-respected Awabba elder. We're invested in creating a culturally safe service, and yeah, it's a journey for us, and I hope you guys will jump on board too. So let's get into the details about what Central Coast Health at Home is. We work out of both Gosford and Wyong hospitals across the whole of the Central Coast, so way down to Brooklyn and up to the far end, just below Morisset of the Central Coast. So we have our hospital in the home team, our RACE, Rapid Access to Care and Evaluation team for the elderly, and our virtual care team, and now Longevity Urgent Care Centre is coming under us as well. So we operate from 8 till 8:30, 7 days a week, and we have the capacity for 40 hospital in the home patients, 20 RACE patients and 20 virtual care patients. Our main goal is really working hard to keep people out of hospital, so we get people out of hospital earlier than they otherwise would, or stop them going in the first place. So we now have 2 medical directors, as I said, myself and Catherine, and we have a team of 6 doctors, senior doctors, who are staff specialists and VMOs. 5 of them are GPs. We're very proud to say 3 of them are GP staff specialists, which is a new thing for Central Coast LHD, and 1 is a geriatrician. We've got a huge nursing team, 36 nursing staff, very experienced, highly skilled nursing team who help provide our hospital level care in the community at people's homes. We've also got a pharmacist on our team and a lovely allied health team now, physio, OT and social worker, and our expert RACE coordinator overseeing the RACE program to help the aged care cohort stay at home independently. And we couldn't do anything without our wonderful admin and data support crew to show that we're really making a difference. So to expand a little bit more about HITH, this is our hospital in the home team, which is the old APAC team. So you may remember APAC, that was typically the service of nurses who would work alongside the GPs in the community to treat things like cellulitis needing IV antibiotics and long-term bone and joint infections. So we've now taken over the medical oversight of that group of patients. So you'll no longer get asked, your GP's asked to review these patients. Our doctors will do that and then hand care back to the GP at the end of the admission. So you think of us like a virtual hospital ward with 40 beds. And so we have to be really strict about this, that the patient would otherwise need a hospital admission. So they'd otherwise be taking up a hospital bed. They need to be safe enough and stable enough to be at home with a safe environment for our nurses to go to. We do see some people who are active drug users, for example, in our clinics. If there's other things that are thought to be unsafe for a visit, we can see them in our clinic in Gosford or Wyong. Instead, if they've got a huge guard dog or something like that, we can see them anywhere really. We've been known to visit people in the car park, at the front of their house, out on the street, in community health centres. So we really try and make it easy for people to access care that they need. At the moment, we're only seeing people over 16, but that's a little bit of a grey area now that we've got doctors on board. So you can imagine GPs, we're really good at asking for help and leaning into our specialist colleagues in hospital. So we can't do, say, people who are waiting for nursing home placement. We can't do people who are sick enough to need help getting to the shower, help with personal care or 24-hour supervision. But we can manage a large cohort of people at home who would otherwise be in hospital. So this sort of group, so cellulitis, UTIs, other infections, pneumonia, needing IV antibiotics, and then you've got the long-term IV antibiotic group for orthopedic infections and blood infections, endocarditis, that sort of thing. We've now taken on a new group of women in pregnancy with severe nausea and vomiting, and this is a really wonderful service because there has been otherwise nowhere for these women to go who have often got toddlers running around and need to wait for up to 12 hours in the emergency department to get IV fluids and anti-nausea medications. So this has been really a wonderful addition to the services for these women. So we can do other things like diverticulitis, DVT and Clexane INR. We've worked for a long time with the surgeons on post-op care and drain management, and we're starting to see a few more heart failure patients who need IV Lasix at home. We can do that, and fluid monitoring. And we're talking to other departments in the hospital about new exciting groups of patients that we might bring onto our service. So there's a novel idea that perhaps people who've had hip and knee replacements could go home on the first day with our nursing team looking after them. The RACE addition to the program has been really wonderful to be able to fast track access to home care packages and support for people over 70 and Aboriginal and Torres Strait Islander people over 50. We have capacity to see 10 patients under the admitted hospital in the home type model with a 5-day intensive allied health intervention. So the physio, OT, social worker perform their assessment and then can fast track access to things like compacts and Transpac to help people who are recovering stay independent. So classically that would be someone who's perhaps had a fall, broken a couple of ribs or broken a wrist, been patched up in emergency, had all their scans, there's no significant head injury or cardiac abnormality, but they can go home, but they'll need some pain relief and overseeing, the fact that they won't get pneumonia, but also implement some home care services so that they can have some help with cleaning and meals and transport while they're getting back on their feet. So this has been really, really fantastically utilised service, and we're looking to take direct admissions now from GP land, which is the reason why I've come on to chat to you guys today. So another just prompt for me to mention the hyperemesis cohort, which are really benefiting from this program. So we'd see women 2 or 3 times a week for IV fluids in our clinic, and our senior doctors have become really expert in managing the complexity of the severe illness that comes with this. Sometimes people are even so desperate that they think about suicide or terminating the pregnancy. So we do wrap around a lot of supports with the perinatal mental health service, and also we can offer these women compacts as well that help with cleaning and meals and respite for their kids while they're suffering and bedbound. So it's a fantastic program. The virtual care team is a non-admitted model. So this is where you have the usual GP would be working alongside our expert nurses who have been traditionally the COVID community support team. You guys might remember that from the pandemic. So they managed up to 700 people a day, managed to keep them out of hospital, at home through remote monitoring and daily nursing phone calls and virtual telehealth. They can send people home with oxygen saturation monitors and temperature probes and other actually pretty fancy equipment we've got our hands on soon, things like virtual stethoscopes, which allow our doctors to hear the breath sounds of someone at home when our nurse has popped the stethoscope on their back. So some really cool tech coming along with these programs too. And we do use an app daily where the patient can report how they're feeling back to our nurses, and then the nurses will check in and escalate to that person's GP. But of course, if it's a Saturday or Sunday, or if the GP is not working that day, they can escalate to our HIF doctors who are always on site. Or they can, of course, get them back into emergency if things deteriorate. We also work really closely with New South Wales Ambulance and also our aged care response team, our nurse practitioner in aged care, and some of the aged care facilities who can refer directly to our nurses. So it's a really great service, and you should think of us for, I mean, anytime you're worried about someone who you're not sure which direction they're going. So it might be that classic Friday afternoon presentation of somebody who has had an exacerbation of their asthma or COPD, or a new viral illness. The GP might start some prednisone and rationalise their asthma puffers, but you're not sure if they're going to get more sick on a Saturday or a Sunday. That's the perfect time to hand them over to our VCAT team, who can do those daily check-ins and remote monitoring to babysit them over the weekend, and then hand them back to the GP and reassure people. There's a lot of anxiety around, acute illness, and our nurses have become really great at reassuring people. Just having that backup phone call contact is often enough to keep people at home and they feel safe and like they've got somebody to call. So it's some really wonderful programs, and I guess overall, the reason to think of our service and use us, there's some I guess public health reasons why we should think about trying to keep people out of hospital. There are only so many, hospital beds that those places can fit inside, and our population is getting bigger and certainly more complex conditions, and so we really need to relieve some of the burden on the hospital, improve bed block, and keep people away from ED when we can. But we've shown, and other hospital in the home services across the state have shown that these sorts of programs have better outcomes for patients. So people get better faster when they're at home. They have less complications like falling over and becoming more confused in hospital, less blood clots, they don't catch COVID in hospital. So really great medical reasons to use these sorts of services. And you can imagine being at home in your own bed with your own home cooked meals and family around leads to very high patient satisfaction. We're having trouble keeping up with all the positive feedback from our patients. Which is really wonderful to see. And if you're a young professional person, you can keep working. Actually, we have some tradies who, who keep going to work with their IV antibiotics hooked up. And really one of the main reasons is so that people can be at home with their pets. We do actually see a lot of people discharging against medical advice early from hospital because they don't have anyone else to look after the dog. So people care a lot for pets, and it's wonderful for us to see that firsthand. So this is how to refer to our service. We have different phone numbers for both HIF and VCAT, but if you call any of these numbers, you'll get put through to the right person, someone who can help you. So really all we ask is that you'll have a clinician think about us, make a call, see if we're appropriate. If you're not sure whether the person is too sick for our service, give our doctors a call and we'll talk you through it. Our nurses are expert and they're really great at saying yes. So we have certainly become the yes team. We try and bend over backwards to make things work to keep people out of hospital. We're also on Health Pathways. And so you can jump on there and find other ways to access our service. And I might just stop there, Phoebe, to just double check to see if there's been any questions about this service. We forgot to say to post some questions online as we go, and I'm happy to get some questions now before I jump into urgent care, which is the topic of the moment. You're all probably waiting to hear about that.
Of course, we have had one question come through, and as Ellie did say, please feel free to send them through throughout the presentation. Question is, are the allied health services, such as for rates, all done by internal team currently, or do you refer to community partner organisations when you have high demand?
Oh, that's a fantastic question. Yeah, so we only use our hospital staff for the acute 5-day admission. So they're really the assessors. They gather all the knowledge and then and they work out what is needed, and then they're the ones who link up with community services that might be needed. So that includes other hospital services and private providers, private allied health and private home care providers. So and certainly the ACAT team and the dementia and behavioural support teams can get involved too. So our race coordinator is the one who puts together, make sure that person is linked up with everybody who needs to be after that 5-day admission is finished. Then they're off on their way. So if you're keen to know more about it, yeah, certainly pop those details or contact me afterwards and we can link you up with Matt Egan, who is the race coordinator, and he can talk you through how to become more involved if you're a private provider keen to help out.
Okay, well, no other questions have come through yet, Ellie, so.
Okay, great. Well, feel free to pop some questions into the chat, and also we're pretty keen to get out to do more practice visits. I have Catherine and myself have been practicing our baking skills, and we're not too bad with baking different flavors of muffins. So if you want to try that out, we'd love to come and see you and talk to your doctors. It often helps to have a doctor-to-doctor chat to introduce people to the idea of these services. We've found that once someone becomes aware of us, they're starting to refer more and more, and they really realise the value of our service. So do pop your name or practice in the chat and or contact me afterwards if you'd like a practice visit. We can organise one of those too. So urgent care, you guys will have heard a lot about this. Now there's sort of ethically and politically charged conversations going around. Certainly there's different models, and we now know about the federal urgent care centres that have been funded through the Commonwealth, 2 of them on the Central Coast, and I'm going to talk about the New South Wales Health state funded non-Medicare urgent care clinic that will be set up at Long Jetty. So this is different to the federally funded urgent care clinics. And Catherine and myself have been involved in some of the I guess the model design to ensure that this service really complements general practice. It's not meant to be a threat to core business, and it's supposed to be an extension of ED for those lower acuity triage categories 4 and 5s that would otherwise end up in emergency. We want to take the load off emergency, see them in the urgent care. So for patients who can otherwise not access their usual GP for those sorts of acute presentations. So there'd be a high focus on musculoskeletal fractures, lacerations, sports injuries. It's projected to open in January. We've been aiming to have a limited opening sooner than that. There are some complexities around setting this up that mean that the soft launch date gets pushed further back, but we have a steering committee and a project officer with now a new clinical lead overseeing the implementation. Dr. Kamal Mazrani is a well-respected local GP working on the project as well. So you can rest assured that there are some good GP voices in the design and implementation of this program. Importantly, there'll be no walk-ins. The triage on all appointments will be booked through Health Direct, which throws up its own set of potential challenges. You may have had some experience with Health Direct, and we have little control over that booking and triage process, but we're certainly in conversation with Health Direct to make it work as best we can. There may be opportunity to create some direct referral pathways in from local general practices. So say you have someone come with their broken wrist, they've fallen off the slide at school, the GP might give them an X-ray form. They can get an X-ray done on the way and come to the urgent care centre for plaster and then access to fracture clinic, which is an exciting development. We all know how hard it is to get people into fracture clinic any other way than through emergency at the moment. So it's going to be a really true collaborative model. So we will work well with the local ED, as I mentioned, fracture clinic and other specialist services that are only accessible through LHD pathways. Access to wound CNCs, their hospital radiology and pathology. Also, of course, health at home. There's a natural synergy between all of those services, and most importantly, to feedback to the patient's usual GP with a summary at the end of care. So the idea is that the patient will present. The whole of that episode is managed and then packaged up and sent nicely back to the GP with little follow-up hopefully required. There's no intention to take over routine GP care that should be managed by the patient's usual GP. So I don't really have too much time to go into the details of what type of presentations there might be, but the triage category 4s are typically should be seen within 60 minutes, triage category 5s within 120 minutes. So you can see the value in seeing these triage category 4 presentations on the list: head injury, minor injury, and minor infections and exacerbations of particular illnesses. It does get a little bit more blurry when you move to category 5, which under the triage scale assessment guidelines should be seen within 2 hours in an ideal world with a flush of GPs and medical resources. But you can see that on this list are things like minor symptoms of low risk conditions, wound review, known patient with chronic symptoms. So I think this gets a little bit blurry, and we'll actually be pushing back on these types of presentations. We don't want to be doing, medical certificates and scripts for hypertension when the patient should really see their usual GP for that. So there'll be some on the ground rules about accessing urgent care centre for those sorts of things, and patients will be told that they shouldn't come for that sort of thing, and otherwise drug-seeking behaviour and things like that. There'll be some policies built around that too. So the hospital did do some analysis of when the highest yield times are for people presenting with triage category 4 and 5. So you can see that the bulk of these presentations happen during the daytime, from early morning to evening. So hence the hours 8 till 8 o'clock, 7 days a week, run by GPs. So the staffing looks like this. Once it gets up and running, there's funding for 1 GP over 12 hours. Now that might be 3 separate GPs working 4 hours each on a day, but there'll always be 1 GP on site. A physio, and actually funding for 4 RNs, so that means that there's a lot of support available for the GP to be providing great wound management and assessment of the presenting conditions. A nurse unit manager and admin will be critical in trying to integrate the hospital medical record with GPland software, which we're aiming to implement, because we really do want this to be a GP-led service that's going to benefit GPs in the local community. And we have already been contacted by a reasonable number of GPs who are interested in doing this work. They are attracted to the acute nature of it. We don't have too much time in general practice anymore to do suturing and plastering and other fun things. So there's an opportunity for people to get their hands dirty with this sort of acute medicine, which appeals to most of us. But it's not our intention to steal staff from you either. So we're opening up the model to ED staff specialists as well to apply, and ED VMOs and CMOs. There is the idea that there'll be X-ray on site. There's some evolving discussions around that, so that might not happen initially, but there'll be pathology couriered to Gosford Lab and point of care testing available. But I guess I just wanted to really reassure you that with so many great GP minds on the implementation and setup process, we hope that it's supporting GP core business, and certainly there's no ability for this centre to bill care plans and other big ticket item numbers that that you may be worried about elsewhere. So yeah, that's the end of my talk, and we've got a couple of minutes for questions. Please take down my email address if you'd like to contact me afterwards to arrange a practice visit, or you've got any other questions you think of at the end. But Phoebe, did we have any more questions?
We did have one come through. Clients on level 3 or 4 home care packages, are they still able to access these services?
Oh, the RACE program, that's a really good question, and that's when Matt Egan, the RACE coordinator, would sink his teeth into the details. Generally, if they've already been approved for home care packages, we'll have some conversations around whether that's still the appropriate level. Does it need to be changed? So it's really person dependent, yeah, case by case.
Sure. And just some praises for you, Ellie. Someone's come through and said sounds really well thought out, and we can tell that a lot of GP input has been involved, so well done.
Oh, thank you guys. Yeah, you can imagine we've lost a bit of sleep over this, being GPs ourselves and knowing what people think about the idea of it, but that's nice feedback. Thank you.
Okay, well, I just wanted to thank you, Ellie, for taking the time for all of your work, but also taking the time to present to us. We really do appreciate it. And to everyone who's logged on today, thank you for spending your lunch break with us. We really appreciate that as well. Thank you so much, everyone, and look after each other. Thank you.
Thanks, Phoebe.